Hello, my name is Jo Porter and I'm the Medical Director of the Breathing Matters charity, which is based at UCL, and its aim is to help find a cure for patients with interstitial lung disease. And I wanted to talk a little bit about the work that we're doing at UCL in an attempt to achieve our aims. So as you are probably aware, the interstitial lung diseases are a group of lung diseases, over 200, that affect the part of the lung that is involved in gas exchange. So here we have a picture of some normal lungs, and at the very end of the airways that branch through the lungs, we have these alveolar air sacs, which are sacs of air lined by alveolar epithelium. And they're in close proximity here. This round thing is a blood vessel, and gas exchange takes place across this tiny thin membrane. And there are lots of these thin membranes throughout the lung. And what happens is when you breathe in, oxygen from the air passes across the membrane and is picked up by red blood cells and taken all around the body to give essential nutrients to every cell in the body. At the same time, the cells give up the carbon dioxide or the toxic gas, and this passes into the lung where it passes across this membrane to be breathed out or exhaled. And it's across these membranes, as I say, throughout the lung that gas exchange takes place. Unfortunately, though, for patients with one of the interstitial lung diseases, this space between the blood and the air becomes filled with inflammatory or fibrous tissue, and suddenly gas exchange becomes very, very difficult, if not impossible. So, for example, in this alveolus, any air in this space is unable to reach the blood, and likewise, any carbon dioxide is unable to be exhaled. So this part of the lung is now no longer contributing to gas exchange, and the patient will be relying on normal lung in other parts. Eventually, as more and more of the lung becomes abnormal, the patient is relying on less and less lung ability. And eventually, unfortunately, in many cases, this will give rise to respiratory failure and ultimately to death. At UCL, our mission and vision are very much aligned with the mission and vision of our Breathing Matters parent charity. So our vision is to deliver precision treatment in interstitial lung disease. So what do I mean by that? What I mean is that we want to make sure that we give the right patient the right treatment at the right time. We want to avoid futile treatments, which may have side effects, but may not improve quality of life or lung function for patients. And we want to institute treatments early in patients who would benefit from them. The problem is, how do we identify which patient will benefit from which treatment at which time? Human beings are very complicated individuals. We're all unique. We all have a unique set of genes and a unique response to our environment. And what we're trying to do at Breathing Matters is try and work out exactly how we can stratify groups of patients so that we can treat each of them better. So our mission in my UCL laboratory is to understand epithelial-leukocyte interactions. And that's a very long-winded way of saying we want to understand how inflammatory cells in the lung, which are a normal part of the lung, they are in the lung to fight infection or disease that might inadvertently be breathed in the air, how these inflammatory cells interact with the alveolar epithelium, because we think that might be the source of the problem that then leads to interstitial lung disease. And by understanding these complex interactions in the normal lung and in the diseased lung, we hope that we'll be able to identify biomarkers. So these are clinically significant markers, either blood tests or scans, that will tell us which patients are going to do badly and which patients are going to do well, and will also guide us as to which patients have responded better to treatment and which patients have not responded so well. And by understanding these biomarkers that tell us about the disease activity, we hope that we'll be able to identify novel therapeutic targets so that we can develop better treatments for pulmonary fibrosis. At the moment, the treatments that we have are limited by side effects, and they don't reverse the fibrosis, they merely stop it progressing. The only cure we have for interstitial lung disease is a lung transplant, which is suitable just for a small handful of people. So this illustrates a little bit more about what I mean by patient stratification. When patients come to us, they're each unique individuals. They may share some features with other patients, or may share very few features. And it's very hard for us to work out exactly how we put these patients into meaningful groups of patients that all behave similarly. So here you see we've stratified the patients so that now they're looking more homogeneous. And we are doing this because we think these patients will behave more similarly to each other than they will to this group of patients. And so by understanding different groupings of patients within our interstitial lung disease community, we can understand targeted pharmacotherapy, so we can give specific treatments to specific groups. And we may even be able to identify those patients that need an early transplant referral. We have very many things that help us with this goal of stratifying patients. The first is our molecular imaging program, which is the first in the world to look at molecular imaging in interstitial lung disease. By molecular imaging, I mean exquisitely sensitive radiolabeled ligands, such as radiolabeled glucose, which are taken up by parts of the lung which are very metabolically active, by which I mean parts of the lung that are busy consuming sugar. So, for example, sugar is consumed by cancers in the body, but also by active inflammation in the body. Any part of the body that is having to do something very quickly and turn things over very quickly will consume sugar. And the PET scan using radiolabeled glucose will highlight exactly which part of the lung is consuming more sugar than another part. And what we've shown with our work is that in patients with pulmonary fibrosis, the ones that have more uptake of sugar on their PET scans are the ones that do less well, even though the patients may look very similar, may have similar lung function, may have similar blood tests and similar CT scans. So this is another way of distinguishing patients from each other. The other tool that we have pioneered, and we were the first in the UK to do this, thanks to the Breathing Matters charity, is relatively non-invasive cryoscopic lung biopsy. Now, normally, if we need a lung biopsy from a patient, and this really gives us information about the type of inflammation that is happening in their lung and the type of mechanisms that are going on in the lung that maybe will be amenable to treatment. Previously, we've had to refer them to the cardiothoracic surgeon to be admitted to hospital for an open operation in which a part of the lung is removed. This can be a 3 to 4 day hospital stay and is associated with a significant mortality and morbidity in this particular patient group. But what we have pioneered is the use of non-invasive cryobiopsy, by which we pass a bronchoscope into the large airway of a sedated patient and pass a probe deep down through the airways to the lung, and we then are able to freeze a bit of tissue and remove it. And it will be in the laboratory by the end of the day, and the patient will ideally, hopefully, be back home. So this has given us not only access to better diagnostics for patients, but also better access to lung tissue. And this lung tissue, if it's not needed for diagnosis, the patients will gift it to us and we'll be able to use it in the laboratory to understand a little bit more about what is going on in the lung. We're also able to look at the genetic factors that are involved in each of our patients and slowly build up a picture where we can give patients a unique idea of their particular disease phenotype and what treatments we think would be suitable. This allows us to do our early phase clinical trials, which are often just in 10, 20 patients, looking at tolerability, feasibility, and safety of various novel therapeutic agents, right up to our more national studies, phase 3, phase 4, late clinical trials, where we're looking at the efficacy of treatments that have been shown to be safe, but we now just need to show that they do improve lung function or they do prevent disease progression and maybe even improve mortality. We're involved with early phase clinical trials teams, the Respiratory Translational Research Collaboration, which is part of the UK NIHR, and also the REMAP ILD, which is looking at using repurposing drugs for use in interstitial lung disease. So drugs that may have been developed for other purposes, but we might want to try them in interstitial lung diseases. So just a quick aside to those, I've said that there are 200 different interstitial lung diseases. And I think really the lung has a very limited way of responding to injury. So if the lung is injured, it will either mount an inflammatory response, and inflammatory cells will be recruited very quickly, or it'll mount a fibroblastic, fibrotic scarring response, in which case fibroblasts will be the predominant cell that's recruited. And a lot of whether you have inflammation or fibrosis or a mixture of both depends on all sorts of things, but in particular, your genetic predisposition. So I always say to my patients, choose your parents carefully. And then the insult that you have received, the cause of the lung damage. Now, in many of our patients, the underlying cause will be an autoimmune disease, such as systemic sclerosis or rheumatoid arthritis, or one of the rarer forms of autoimmune disease. Some of our patients will have interstitial lung disease as a result of infection or other inhaled insults. So we've been seeing pulmonary fibrosis after COVID-19 infection. We see it sometimes an interstitial lung disease after vaping. We also see interstitial lung disease in the context of drugs and dusts. There are specific drugs that we know cause interstitial lung disease, such as bleomycin and amiodarone, and other drugs like nitrofurantoin that can in a small number of people, again, depending on your own genetic background. And then there are a group of diseases called the granulomatous diseases. These include diseases such as sarcoidosis, tuberculosis, ANCA-positive granulomatous polyangiitis, hypersensitivity pneumonitis, where we get what we call granulomas formed. And these are granulomas as very specific groups of inflammatory cells that we see on lung biopsy. And when we have excluded all of these by taking a really good history from our patients, it's a little bit like the television program House, where they try to work out what has caused the problem in the patient. Then what we are left with is the truly idiopathic. And one thing I would say is really, it seems to be almost independent of the insult, independent of your genetic background, whether you mount an inflammatory or a fibrotic response in the lung. And most people will have a bit of both. And even in the same lung, there may be patches of inflammation and patches of fibrosis. But what we do know is that by understanding the degree of inflammation, then we may be prompted to try anti-inflammatory drugs. If we understand the degree of fibrosis, then we may be prompted to try anti-fibrotic drugs. So understanding where an individual patient sits here is very, very important. And part of our goal with our imaging and our biopsies is to see if we can understand this spectrum much more accurately and much less invasively. So ideally, a blood test or a scan that would tell us exactly whether there was predominant fibrosis or predominant inflammation, and therefore what the best treatments would be. Now, this is a complicated picture, and I apologize, but now we are back in the alveolar space. And here I want to demonstrate that for all the 200 different interstitial lung disease, what we think is happening is that there is an injury which causes death of these little flat cuboidal type 1 epithelial cells. Now, when these are damaged, they die and a space is left. And it's very important for the body to close that space very quickly, because it's all that is between the outside world, the air you breathe in, and your blood supply. So the type 2 epithelial cell will divide to give rise to more type 1 epithelial cells. And if you're young and healthy, that's relatively simple. But if the injury is widespread and you're already a little bit older, you may find that your type 2 epithelial cells just cannot produce the type 1 epithelial cells to close that gap anymore. And your body is then left with a concerning area that it needs to seal very, very, very quickly. So it goes into repair mode, and immediately you have release of clotting factors from the nearby blood vessels, and these clotting factors bring in fibroblasts, which then lay down collagen or scar tissue, so that that blood vessel is now no longer so directly in contact with the outside world. It is protected, but in so protecting it from infection or damage, the body has also meant that it can now no longer be accessible to gas exchange. So it's a compromise. On one hand, the body has to seal that gap because it is your Achilles heel. On the other hand, if that gap is sealed and the collagen is too thick and too unwieldy, then gas exchange will no longer be possible. So you can see that it's a very, very complex system, and we just do not want to disrupt things too much, but we just want to get back a nice balance. Now, what we've been interested in Breathing Matters is the role of coagulation. So this very first step, there is blood clot formed, and it's the blood clot that seals the gap initially, as with any wound, and then recruits fibroblasts. We're also interested in new blood vessel formation, because that certainly seems to be a feature, that through this scar tissue, new blood vessels form, but they're not really very efficient at gas exchange because they're so far away from the alveolar space. And then we're also interested in the mechanisms of fibrosis and the laying down of collagen. Now, my own laboratory's work has focused on these blood cells called the neutrophil. And some of you may have seen our work published earlier this year on the neutrophil lymphocyte ratio as a predictor of mortality in interstitial lung disease, specifically idiopathic pulmonary fibrosis. And what we showed is that we took patients at diagnosis and measured their neutrophil to lymphocyte ratio. We could tell whether patients were going to progress quickly or whether they were going to progress more slowly, depending on that ratio. The other work that we've done has been looking at hypoxia, which is low oxygen levels in the lung, and how that might affect these events. So neutrophils are recruited into the lung as a result of this injury. And when the neutrophils get there, they do something called neutrophil netosis. They throw out these vast nets which ensnare microorganisms during infection, but also form a nidus for further coagulation and further disruption of the milieu in the lung. And what we think is that these nets lead to extrusion from the neutrophil of a molecule called LRG1 or large 1, which drives the new blood vessel formation. And the new blood vessel formation per se is probably not such a bad thing, but what it means is that blood is deviated to parts of the lung where it's not really engaging in gas exchange. What we also know is that large 1 may play a role in fibrosis, and our ongoing work is looking at this. Now, our molecular imaging studies are able to report some of these events, which is wonderful. So we can use a ligand called F-MySO, which tells us how much hypoxia there is in patients' lungs. And interestingly, actually, we find there was remarkably little hypoxia, even in patients with relatively low oxygen. But we're also able to detect new blood vessel formation using radiolabeled glucose or fluorodeoxyglucose. And there's also interest in some beautiful new molecular imaging tools, such as FAPI, fibroblast activating protein inhibitor, and somatostatin receptor 2 ligand. So these are molecular imaging tools which will tell us exactly in an individual patient the contribution of these different events. As a result of understanding the importance of these events, we're also involved in some drug studies which are looking at preventing these events in patients with pulmonary fibrosis. So we're about to publish a study where we looked at anticoagulation in patients with pulmonary fibrosis. We've also interested in a study looking at Dornase alpha to reduce netosis in pulmonary fibrosis. And we have an antibody against LRG1 called magicizumab, and also a molecule C21 in trials at the moment, which we believe may impact on the neoangiogenesis and the fibrosis that we see in pulmonary fibrosis. So we are bringing some early phase clinical assets into clinical trials at UCLH. Another area of a great deal of interest to both us and other researchers is the role of mucin 5B. Mucin 5B is an airway mucin. We all produce it. And what we know is that in some patients, 1 in 20 of us will have a different genetic polymorphism for the promoter region of MUC5B. Now, it's thought that this probably results in more MUC5B being produced in response to any given stimulus. What we know is that although 1 in 20 of us have 1 or 2 copies of this gene, it actually increases our risk of pulmonary fibrosis by about 12-fold. Now, what that means is pulmonary fibrosis is still rare, and most people with the MUC5B promoter polymorphism will not get pulmonary fibrosis. But if you have a strong family history and an insult, and you have the MUC5B promoter polymorphism gene, then you are more likely to develop pulmonary fibrosis. And we've been trying to understand why that might be. It's not just the mucin 5B that we're interested in, we're also interested in other mucins. And I haven't told you what mucins are, but mucins are proteins produced in the lung which have a lot of sugar molecules attached to them, which mean they retain a lot of water and they become very, although they're liquid, they're quite thick liquid, and it's the mucus that gives your phlegm that stringy quality. And what we know is that in patients with pulmonary fibrosis and in patients with cancer, some of the biomarkers, so some of the markers that we measure in the blood, are actually shared between patients with cancer and patients with interstitial lung disease. And many of these are mucins, such as mucin 1, which also is the basis of the CA15.3 assay in cancer, KL6 or mucin 1, which is sialylated, mucin 16, which is CA125, and sialo-Lewis X, which is a glycoprotein but not a mucin, CA19.9. And of course, large 1, our molecule, is also a heavily glycosylated protein. So all of these, including MMP7, which cleaves some of these mucins, are up in cancer and in pulmonary fibrosis. And what we are trying to understand is why that is, and the role that these proteins play. In many cases, these proteins are found in normal lung, but they're found in more abundance or with different sugars attached to them in the cancerous or the pulmonary fibrotic lung. What on earth are they all doing? So one molecule that we're particularly interested in my laboratory is mucin 1. So mucin 1 is actually expressed on these alveolar type 1 epithelial cells. And we all have it. We all have mucin 1, but it is upregulated when there is injury or damage. And when there is damage, it also becomes sialylated. And this sialylated form of MUC1 we call MUC1-ST. And we know that MUC1-ST is able to signal to inflammatory cells within the alveolar space to make them behave differently. And we know in cancer that these macrophages or myeloid inflammatory cells become more permissive to the growth of cancers. Likewise, we believe that they become more permissive to the development of fibrosis. So this is a really exciting and very new area, suggesting that proteins in the lung that become aberrantly glycosylated or aberrantly sialylated then signal to inflammatory cells and change their behavior to become pathogenic. So I hope that that has shed some light on our work in interstitial lung disease and some of the ideas that we have been developing at the Breathing Matters charity. We're very grateful for all your funding, and we hope that we will go on together to eventually cure pulmonary fibrosis. Thank you very much for your time, and do visit our other parts of the website where we talk a bit more about our research in detail. Thank you very much.